So those of you who may not be able to use the QR code at this point of time, no worries, we'll share it again at the end of the presentation. And this, once again, is a proud sponsor by GE Healthcare. So we're very thankful to have them on board with us today as well. And we have an excellent lineup of speakers today. For those of you who want to know who are our distinguished speakers, we have the first speaker on board with us is Dr. Nurul Norzan, who is based in Hospital Sungai Buloh, Malaysia. The second speaker is none other than Ms. Nicole Kelly, and she will be presenting on the topic, the trauma nurse, clinical roles and distribution, all the way from the Royal Adelaide Hospital, Australia. The third speaker is Dr. Yeoh Chiat, who is one of our fellows who's currently based in the Royal Adelaide Hospital as well, and he'll be presenting live from there as well. Last but not the least is this one of our really distinguished guests, who is Professor Dan Ellis, who will be giving the topic on resuscitating the critically ill patient, what really matters. So we've got the best at the end of our presentation, so please do stay tuned. And once all of our speakers have completed their presentations, we will kindly move on to the Q&A session, of which some questions will be vetted and shared with our distinguished speakers to get the best experts in the field. And last but not the least, we have Dr. Shah Jahan and Prof. Daniel, who will summarize and give their best expert opinions at the end, just before the closing of this entire talk. I hope all of y'all will enjoy this entire CME. So allow me to introduce in depth of each of our speakers. So the first speaker is Dr. Nurul Norzan, right? And her topic for presentation is trauma administration, trauma team leadership and training. So Dr. Nurul she has a Bachelor in Medicine from, or rather MBBS from the International Islamic University of Malaysia back in 2005. And she obtained her Master's in Emergency Medicine in University of Malaya in 2013. She is currently a consultant trauma physician, of which she got her subspecialty from the McGill University based in Montreal, Canada. And Dr. Noor is currently working as a consultant emergency physician in Hospital Sungai Buloh, Malaysia. Moving on to our second speaker is Miss Nicole Kelly, and she is based in Royal Adelaide Hospital. So this is a bit about her. Nicole is the Trauma Service Nursing Director for the Royal Adelaide Hospital and the nursing lead of the South Australian Trauma System, as well as a co-chair for the South Australian State Trauma Committee. And she is also a member of the Royal Australasian College of Surgeons, South Australia Trauma Committee. She has over 23 years of experience in emergency nursing and trauma, and she has been the integral part in the development of the South Australian major trauma system, as well as a pioneer in the trauma nursing career pathway and service delivery models in South Australia, and is considered an expert in her field across Australia and internationally. Her professional portfolio includes the operational and strategic management of a trauma service. She has led the establishment and leadership of a team of trauma nurse consultant case manager service across 7 days at 2 different South Australian hospitals and supported hospitals around Australia, with the development of their trauma nursing service. So Miss Nicole Kelly will present on the title, The Trauma Nurse Clinical Roles and Contributions. Moving on to our third speaker is none other than Dr. Yeoh Chiat. So Dr. Yeoh Chiat is currently a trauma fellow in emergency trauma clinical care, and he's currently based in Royal Adelaide Hospital, Australia, at his final year. Dr. Yeoh graduated from University of Science back in 2010 and subsequently completed his postgraduate specialist training in emergency medicine at University of Malaya back in 2019. And following which, he is an experienced emergency physician based in Penang Hospital up north in Malaysia. So Dr. Yeoh Chiat will present on sternal fractures, management, and outcomes. Right? So the last but not the least, we have Professor Daniel Ellis, who is none other than the Director of Trauma, Royal Adelaide Hospital. He is also the co-chair, statewide South Australian Trauma Service, Trauma SA. He is also the consultant in emergency medicine in Royal Adelaide Hospital. He is also the pre-hospital and retrieval physician, or rather known as SAAS, MedStar, and is in charge of the Emergency Medical Retrieval Service. He also holds a role as a clinical associate professor, Faculty of Health and Medical Science, University of Adelaide. And he is also an associate professor in the School of Public Health, Tropical Medicine, James Cook University. And Prof. Dan will give the topic, will enlighten all of us on the topic with the title of Resuscitating the Critically Ill Patient, What Really Matters. So I hope everyone is excited as I am, right? So to get the ball rolling, shall we start with our first speaker, Dr. Azlean? If you're ready, Dr. Azlean Norzan, the floor will be yours. So Dr. Azlean will be presenting on trauma administration, trauma team leadership, and training. Dr. Azlean, the floor is yours.
Thank you, Dr. Datini, for a very kind introduction. Okay, well, I'm trying to share my screen. I think Dr. Datini need to unshare it. Okay. Yeah. Okay, now I can share it. Right. So thank you again to Dr. Ratini and the team. Thank you for inviting me to join this, I would say a small mini conference. I would say it's like 4 speakers at one time. And I'm going to presenting about trauma team building leadership, leading with clarity, confidence, and collaboration. My name is Dr. Azlean Norzan, and I believe that Dr. Ratili has introduced me well just now. So why not we just proceed with the next things. So the objective of my presentation today, we like to understand the key roles in the trauma team. And apart from the readings, all the principles, identify the common leadership challenges, trauma setting, and just to know that we are going to basically break down the trauma team leadership in not just as a role, but of course is as a set of behavior. So whether we are emergency physician, whether we are medical officers, or whether we are nurses, staff nurses, or assistant medical officer, housemen. So leadership in trauma is everyone's responsibility at one point. So there will come a time that you have to step up as a leader and take up the role and the responsibility. Okay, all right. So the trauma team, who's in it? So basically, as I said, there's a lot of players that coming through whenever we activate or whenever we are managing a trauma case, especially the polytrauma. They can be as little as 3%, or it can be as much as like 20% in one time. So it very dependable on the case. But however, every trauma team is a team sport. So as a team leader, we should understand who are your team player, and then what can they bring into the table when managing a very severe polytrauma, for example. Okay, so trauma team basically is a team of experienced medical professional designated with pre-identified roles to provide immediate care to the major trauma victim by a recognized activation process upon or prior to the arrival of a major trauma victim at the emergency department. So in Malaysia, we have a Malaysian trauma chain of survival, which started with early activation, pre-hospital trauma care, and subsequently followed by the trauma life support and resuscitation, emergency surgical or critical intervention, intensive care, and advanced therapy, and subsequently, not the least, is a trauma rehabilitation to bring all these trauma patients back to the pre-morbid or pre-injury lifestyle. Okay, so what makes a trauma team or the activation success things to do? So first, it's not just one horizontal, or it's not actually a vertical approach anymore. It means there's no one leader leading everything and dictating everybody to do, but it's more on horizontal approach in clinical resuscitation. So means that it is needed that the trauma leader is needed that to ensure that all the team players understand what their roles and their responsibility during the clinical resuscitation. And of course, it's been accelerated with the accelerated clinical decision making will improve a clinical patient's outcome, and subsequently, most important, I would say, is effective interspecialty team communication. So with all these three coming as in one at one time, it will help in successfully resuscitating a patient and subsequently contribute to the improve patient's outcome. Okay, so I just want to share with all of you the two-tier trauma activation in Hospital Sungai Buloh. And this is to improve a patient outcome and allow sustainability and reduce desensitization. So as you can see here on the right side on the green chart, right? So we have the first tier, and then where we activate tier 1, the trauma alert, we activating the tier 1, and subsequently the trauma patient will be brought to the trauma reception, the DCR, damage control resuscitation suite, and subsequently it will go into the trauma alert tier 2. So what does it mean by first tier and second tier? So the first tier means there's an ETD trauma resuscitation staff, which comprise of our emergency physician who actually on the floor, or patient actually, together with the emergency physician, trauma physician, medical officer, staff nurses, and also assistant medical officers. Not to forget our other team members that actually will help around. It could anybody that actually coming over. So that is the first tier, and this first tier ETD trauma resuscitation staff will do a primary survey and detect a life-threatening. Subsequently, when it's not necessarily you have to be in the secondary survey or what, but at when the first tier or when the primary survey has been done and some injuries which is critically ill need to be addressed to, and needed for the secondary team to come in, which is the primary specialties, then the second tier trauma activation is activated. So the tier 2 activated should be activated appropriately according to the cases. So this is a very high, I would think, is very high factor to reduce the sensitization or to desensitization to any trauma activation. Because if we're calling wolf, I would say, if we're calling wolf every time we call, so eventually the the team will be sensitized, and they will eventually send the most junior one to come down and, doing the resuscitation in fact, a very severe trauma, polytrauma patients. Okay. So the activation via operation will be via the operator switch box, and it based on the injury patterns. So with this, we can reduce, we can optimize the resource, and there will be experienced responder and reduce desensitization. Sorry. Okay. So now we are talking about core leadership principle. So as a team leader, we understand that should be aware of the situation. So we should be aware of the situation of the patient. We should be aware of the situation of the team and also of the surroundings. So if you as a team leader, we don't aware of the situation, about your situation around you, then it's gonna be like unorganized chaos. But we want to change the chaos into the organized chaos. So it's very important for us to understand that we need to be aware of our situation, and with that, clear communication with the team member and the team, or I would say even in between the two specialties or three specialties who actually come and see this patient is very important factor to improve the patient's management and ensure that the care can be given successfully. Define roles. Define roles as what? For example, in very simple way, we can define role in the tier 1, for example, like we can define our staff. We have, let's say we have 5. We can define into airway, we can define into circulation, and etc. And definitely defining roles is important to make sure that team members understand what their roles and responsibility during the resuscitation. So as a team leader, when we assign the role, it will be very easy for us to pinpoint or to know which one of the staff is doing what. And every time when there is a situation happen or anything, critical condition arises, so the feedback from the team member comes from the one group of people. So we understand and we know this is the problem that happened at that point of time. So not lastly, but number 4 is a control calmness. So when we managing a chaos, unfortunately, as a team leader, we have to be calm, but we can create a state of control calmness, although inside is very turmoil, right? But we have to be calm in terms of to ensure that our team member doesn't pull into the situation at the point of time. So I hope you guys will understand what I mean, but it just means that if we are not calm, so the team will be in chaos because they are just like there's no leadership. All right, it's like what they call it, a ship inside a turbulent sea. And last but not least, in the core leadership principles, it's very important that we can make a decision. So decision-making tools, there are a lot of decision-making ways, and of course, we have to be open. And we have to be open with the suggestion and eventually come to the one decision making. Okay, let's do. So the leader's role, the trauma leader needs to understand that the role doesn't start during the resuscitation. It even starts pre-arrival. We have to prepare and brief the team. During the resuscitation, lead and delegate and also adapt, just in case you need to change. And post resuscitation, of course, the debriefing and also to reflect the cases that we have undergone through. Okay, so leadership have many. I would say leadership has so many style. They have directive, they have facilitative. Okay, so directive, as you all know, we are directing. It's more like probably some kind of like vertical management, but we are trying to move away from that. So we are more on horizontal, but still in the directive way. Or we can provide a facilitative leadership. So a trauma leader needs to understand that the team member, who are the people in their trauma team, whether actually what they can bring onto the table, or what can they bring into the team in order to facilitate the management. For example, if your team member have expertise in terms of airway, and why not facilitate them to become a airway management expert in your team. So you can sort of like what do you call it? Cognitively, you can actually release the cognitive burden of yourself as a leader, because you know somebody is expert, is managing the airwave. And the leadership style, actually we can, as a trauma leader who experience, it can matching style to the scenario. It depends on the scenario to scenario. So it doesn't have to be a very rigid leadership. That's what I mean. Okay. So as we go to a case scenario, so let's just us reflect.
Ketamine sucks on board.
Pulse ox holding at 94. Prepping the neck just in case.
Let's have a look. A little deeper.
Lots of swelling. I can't see the cords.
To the right. The left. Yeah, really distorted from the trauma, and the demon's only going to get worse.
Which is why we should crike.
You don't crike a laryngeal fracture. Don't listen to Edwina Scissorhands here. If they can't cut it, surgery doesn't know how to fix it.
The contusion is high at the thyroid cartilage, so you just stand there looking pretty, ER Ken, and let me fix this.
We're down to 85. All right, pull out eye-gel, bag and crike.
Eye-gel, please.
Turn off the alarm.
I've never done a crike before.
No, Mel will do the crike. You've already had a busy morning. Glove up, Mel.
No, I'm doing the crike, doctor.
You would be doing it, doctor, if it wasn't an odd day. Surgery gets even days, ED gets odd days. You know this, for Christ's sake.
It's because you're all fucking odd down here.
Okay, teamwork, please. Let's focus on the patient. I so appreciate your gracious understanding.
I'll assist in case she screws up.
Yolanda, play nice.
Stats are up with the eye gel. You ready? Hello? Oh, hello. You've done this?
Okay. Teamwork. Teamwork. Play nice. And teamwork. Please focus on the patient. So these are the one thing that some sentences that we can use in terms of like neutralizing the situation when there is a heated communication between the team. So as you can see there, probably who takes the lead is a team leader, but the one who actually doing the resuscitation is the team members. And there are communication challenges that you can see in this video, communicating between two team members who actually has a contradictory decision making on what to do on the patient. And whether actually decision made under the pressure, it all depends on the trauma leader who have to analyze in the calm situation, analyze the scenario, and give the ultimate decision. So common in terms of your leadership, as leadership challenges. As a trauma team leader, we have a lot of resistance, confusion, and even conflicts. So our role as a trauma team leader in the situation is to manage it, and not just the patient, but also the team. So as you can see here, there are a lot of factors that can affect the communication or the leadership. So one thing is about hierarchy, fatigue, is an disagreement between the team members, and also not the least is an inexperience. So as you can see, all this actually can be a stress factor to the team, the trauma team itself, while managing a very highly critically ill patients or trauma patient per se. So how we're building this leadership skill? So leadership skills is not born. I mean, probably one in, I don't know, I cannot give numbers, but probably there's somebody actually born with leadership skills from birth. But I don't pretty sure we do have that, but we do, and we can build up the skills. So in Malaysia, we do have a few how to build build leadership skills. One is a simulation training. So how does this simulation training build up the team leader? I mean, not the team member. We are always thinking that, oh, simulation training is for the team member. I mean, we want to improve the team. I mean, your staff nurse or your medical officer or residents knowledge in terms of like understanding the guideline of certain scenario or certain conditions, right? But it's actually show if it can be done successfully. It's actually show that you can lead the simulation. And of course, in simulation training itself, is not just telling them what to do and what, but also to simulate the situation and then appoint them to become leader. So it become a team leadership skill training as well. So we have a trauma life support where we actually one of the stations is actually building up as a trauma managing patients, polytrauma patient as a trauma team leader. Okay. So we also have another high fidelity procedure skill training program, and this is to improve the competency level of the trauma team leader or emergency physician into a better or more expert way of doing procedures in emergency department. So how does this actually building up your leadership skill is actually build up your confidence and clear your mind in understanding what are important in terms of managing a very severe trauma patients. So there are many things that we learn through this. I personally learned a lot from these procedures or this workshop, and it's actually improved my confidence level as a trauma team leader. And building leadership skills, of course, one thing is important is about the real-time feedback. So whenever we do things as a senior to the junior, we lead by showing some example and giving them feedback. Giving back feedback doesn't mean have to be a buttered effect. It can be very direct, no butter, no long, direct to the point, so that the receiver will understand what are the things needed or what are the things they have done that is wrong. So this is very important during the trauma team activation, because the real-time feedback is what stick to the mind. And as the team leader, we should be able to detect during the chaos, detect the problem, and subsequently give the feedback. So some will appreciate this feedback, it will stick to the mind, but some will take it and dismiss it. But it's fine. As a trauma team leader, we should be able to give a real-time feedback so that it will improve the overall patient's outcome. Okay. This is one important thing at the end of the resuscitation. It's a reflective practice of the every trauma case or every trauma case or every cases in emergency department that we face. So we need to debrief the staff. So understanding what's happening and then understanding what are the effect that we did on the patient. Perhaps there are something that we did good, or perhaps there are something we did bad. And then we need to reflect, and from this one, after we reflection, then only we can grow. So as a leader, we should be able to debrief it appropriately, try to understand what are the team members, I would not say feeling, but more on like empathize them of what into their understanding of the cases, so that some of the staff probably couldn't handle it, some of the staff could handle it, because this is very important, especially in the new, I would not say new, maybe perhaps seasoned staff as well. In a very traumatized patient, probably this will affect their side or their trauma, post-trauma PTSD, I mean. Yeah. Okay. So another way of building your leadership skill is actually to mentoring the juniors. So we can do a lot of training, and also in Malaysia we have an advanced diploma in emergency care, Adelaide, for our staff nurses and also our assistant medical officer, in order for them to learn in depth regarding a trauma patient, trauma care. But ADAC doesn't just limited only to trauma. They have critical care. They have a lot of other things. But when they are going through this training, in a way, they will build up their confidence and their knowledge, and subsequently they will be able to become and take a role as a leader or the trauma leader if needed to. Okay. For the doctors, there is a program which is what we call as trauma physician subspecialty training program, which is what we are undergone, and Dr. Yeoh is doing now. And this is a 1 year, 3 years program with 1 year attachment at the international institution. So with this, actually, will improve. There's a lot of exposure and also things that we have to do as a trauma physician, and this special training actually can will mature us into a more confidence and with more clear of what we have to do as a trauma physician. So I think take home messages. Leadership is a behavior, not a title. So anybody can become a leader. So how you behave as a leader is important, and as much as we can, because trauma team in the trauma activation is we have a very short time to become a leader and subsequently to manage and subsequently to control the chaos that happening within 1-2 hours. Right? Even in very bad way, it can go up to 12 hours in some cases. So know your team and their strength. Understand what they can bring to the table and understand what they can contribute to the team in order to ensure the better outcome of the trauma patients. Practice calm, confident communication, and don't forget, debrief, reflect, then we can grow. So with that, I thank you.
Thank you so much, Dr. Nurul, Azlean, Norzan. Wow, I really enjoyed the entire presentation. It was very insightful, Dr. Azlean. And for the audience, just keep those questions coming in. We would love to address those questions at the end. So whatever queries you have, just put it on. We'll get that addressed at the end of the presentation. So thank you, Dr. Azlean.
Thank you.
So without further ado, I would like to introduce our next speaker, Miss Nicole Kelly, all the way from the Royal Adelaide Hospital, Australia. And welcome on board, Miss Nicole. I hope you're having a good time over there. Yeah. All right. Okay. So Miss Nicole, she'll be talking on the topic of the trauma nurse, clinical roles and contribution. So Miss Nicole, the floor is yours.
Wonderful. Thank you very much for having me. I really appreciate the invitation to speak. I'm just making sure you can see my slides okay? And is it you can see the full screen, is that okay?
Yep, you need to share it on.
Oh, I believe I already am. Let's see. Is that any better?
Not yet. Yep, perfect. Carry on.
Okay. So full slide, not my screen. No, yeah, wonderful. Thank you very much for everyone for inviting me to speak. And I hope that I don't use too much Australian slang or aqualism within the way I speak, but thank you for the lovely introduction. I did prepare a quick introduction, but just to give you some background, I have got 23 years of nursing experience. My background is critical care nursing, both in the emergency department and more specifically in the last sort of 18 years as a trauma nurse. Initially, I spent most of that time in a small metropolitan hospital that would receive major trauma patients via ambulance, but then would be able to only stabilise those patients and then have to transfer those more critically injured patients to a major trauma centre. But we did most certainly manage a lot of moderately injured patients within our hospital. And at that hospital, I was the lead of a nurse-led trauma service without any medical head of unit because there wasn't funding for one of those at a smaller hospital. In the last 8 years, I've been working alongside Associate Professor Dan Ellis, who is your other guest speaker a bit later tonight, and we've been co-chairing the South Australian trauma system to improve it and develop a lot more system and governance type wide improvements across South Australia. And for the last 4 years, I've been here at the Royal Adelaide Hospital, and that's where I got to meet Dr. Chun while he's been working with us and evolve our trauma nursing service here over the last few years. And as a trauma nurse in Australia, trauma nursing has been sort of a core role within trauma services across Australia and New Zealand for over 20 years in Australia and widely in the USA, but more so to do with credentialing as well as the work that we do as a trauma nurse in Australia and New Zealand. But I work not only within my own state, but also we have representation statewide and nationally on a lot of quality improvement and data governance and system-wide steering committees. So the Royal Adelaide Hospital, where I'm presenting from tonight, is the major trauma service for South Australia. We care for patients who we consider adult-sized patients in trauma language, which is 16 years or above. And we have the services to provide care to the most severely injured patients in South Australia. We have been verified or accredited is another terminology, but verified as a level 1 trauma centre via the Royal Australasian College of Surgeons verification program last in 2023. And that's a 5-year verification process. So every 5 years you go through that benchmarking process to make sure you meet all the optimal levels of trauma service provision. We treat over 3,000 trauma patients per year, and approximately 700 of those are classified as ISS greater than 12s. Now, we know that's quite small compared to other areas around the world, but for South Australia, that's the biggest service, and we're the 5th busiest trauma service across Australia and New Zealand. Myself and Dan, I mentioned, is the statewide co-chairs, and our service provides leadership and governance across the state, as well as patient-facing services, education, research, injury prevention, and QI for trauma care in our hospital. Our trauma service is multidisciplinary. Myself and Dr. Ellis are the leads of our trauma service, and we have a medical team of trauma fellows, so they're fellowship trainees with the Australasian College of Emergency Medicine, and we also have some dual accreditation for anaesthetic training as well. We have registrars that work with our service across 7 days and cover 24 hours a day and work closely with the emergency department medical team in that high-performing team model that we've just heard about. And we've got a trauma nursing service across 7 days, as well as an injury prevention team and also a research coordinator who has a nursing background. We also have amazing administrative support, which I'm sure you can all agree is very helpful in a busy service. But our trauma service is the core coordination and oversight and governance of the trauma care a patient receives. But of course, we need to do that in really close collaboration with the ambulance service, with the emergency department staff, the intensive care unit, our trauma surgeons, anaesthetics, all the other specialty services of surgeons and specialty other clinical units that need to be involved in a complex trauma patient's care. All the clinical support services, including blood bank and radiology, and of course, the support of allied health and rehabilitation pathways. And that's what makes up a really robust trauma service and system. And I'm starting this off because it's really important to paint the picture of where the trauma nurse fits within this system. In South Australia, we've got a robust trauma model of care, and it looks after the continuum of care of the trauma patient, from injury prevention all the way through to post-acute care in rehabilitation. It includes along the way data collection and analysis of that and looking at our outcomes and measures, making sure we're utilising research to really ensure we're doing best practice care and challenge the way we do things, education and really robust clinical case audit and review to see how we can always be improving. So I mentioned the Royal College of Surgeons Trauma Verification Program earlier, and like I mentioned, it was a 5-year rotation. This is what trauma service across Australia and New Zealand aim to meet the criterion of. And within this, they have lots of different modules, but one of the modules that I'll focus on tonight is about the trauma staffing and of your service. And very much the trauma staffing talks about medical roles, but within Australia, New Zealand benchmarking, there are some really core roles of trauma nurses that need to be part of our service. And that includes overarching trauma nursing leadership of the service, as well as specialist nurse specialists in trauma care, and to provide a case management type model. And I'll explain what that means shortly, as well as a trauma data manager. And in Australia and New Zealand, trauma nurses are quite heavily involved in the trauma data management and looking at quality improvement and outcome measures of the service. And quite often our research coordinator is a nursing background as well. And there are some websites that you can look up in Australia and New Zealand that talk about those. So the New South Wales Institute of Trauma and Injury Management have some guidelines, but you'll notice that there are lots of different names for them. There could be the trauma nursing roles could be called trauma coordinator. I've been called one of those in one of my previous roles, a trauma case manager, which quite often the trauma coordinator does case management as well. A trauma data officer, like I mentioned, quite often nursing background, but can be administrative as well. And then quality improvement and research support officer, quite often this person is a nursing background. And then sometimes multiple hospitals in a cluster across Australia and New Zealand may have one trauma nurse that coordinates across that jurisdiction of the different hospitals. But ultimately, these roles sometimes can be one person doing all of these things in a really small hospital, or it could be multiple roles. In New Zealand, the trauma nursing model, they do have this document, and I've popped the QR code there for you if you want to scan that to take you to the link to that. They've got a professional development framework for what they suggest the different types of trauma services should have in terms of trauma nursing roles. And very much from the nurse that was working in ED and on a ward that's got specialist trauma nursing skills, as opposed and then through to a trauma nurse that's her specialty area, that is his or her own role, all the way through to advanced practice roles like the trauma nurse practitioner role that has advanced clinical skill sets and credentialing for prescribing and doing procedures and ultrasound and things like that. But across Australia and New Zealand, we're actually doing a bit of a survey at the moment, because we've found that there is so much variability in the titles that we call trauma nurses and also a little bit of variability about what their role is based on those titles. So this is just a few of the different titles. So you'll see trauma nurse navigator, trauma nurse consultant, trauma nurse specialist, case managers, coordinators, program managers. But whilst they've all got different titles and might have a slightly different career structure and different pay grades and things across the country, depending on what jurisdiction they're in, they might also have different clinical backgrounds. Majority of trauma nurses across Australia and New Zealand are actually critical care background nurses, those with specialty emergency or intensive care unit postgraduate degrees on top of their basic training. And they may also work within different models and have slightly different roles, but their roles do similar things. And generally, a trauma nurse tends to be a bit of a jack of all trades. I don't know if you understand what that is in Malaysia, but it tends to be a very flexible role that can do a bit of everything and kind of fix everything that needs to be fixed. But like I mentioned, the service models and trauma nursing models can be quite different depending on the size of the service, the busyness of the service, and how much funding they've got. You know, also it just really depends on what the needs of the service are. There are clear responsibilities, though, across all trauma nursing roles. It's nursing leadership of trauma care. We know that in many centres across the world, there's very strong medical leadership, whether that's emergency department, consultant leadership, or trauma surgeon leadership. But it's really important to also have trauma nursing leadership within a trauma system. For those that have got expert clinical nursing care that can really provide and support expert hands-on delivery of care from a nursing perspective and guide the practice of the junior staff. coordinate the care with rounding and case management, patient and family communication, and making sure the patient's involved in the journey, quality improvement programs and projects. Like I mentioned, a lot of work with data and the trauma registry and coding, and the development and maintenance of guidelines, education and simulation, research and prevention. So these are the common themes across Australia and New Zealand that all the trauma nursing roles undertake. We tend to be the glue that holds everything together. The trauma patient, as we know, is really complex. They quite often have a very long list of injuries and might need this specialty input from lots of different teams. And that can make things very complex with miscommunication between different teams, with different teams having different priorities of when they want their care delivered or their operation done. And sometimes those plans change multiple times for a complex trauma patient. And so coordination of that, liaising with the multiple teams and making sure the patient and their family understand that process is very important, because we meet patients in the most traumatic circumstances, in the worst day or time of their life. And the thing that can make it, only thing that can make it better for them, apart from the great clinical care we can provide, is by remaining informed and supported through that journey. We can't take away what's happened to them, but we can make their experience much better. So we provide a familiar face for the patient and the family. We provide complex care coordination. Patient and family are involved, and so the psychosocial support's important. Ensuring the tertiary surveys are done, that they don't get lost. We obviously do the primary and secondary survey in the emergency department, but tertiary surveys down the track are really important to make sure we don't miss injuries. Early identification of the deteriorating patient, and picking up on signs of the patients changing because we know them well, because we're case managing them across their journey, and involving different insurances. Most of our trauma services and systems in Australia are public health systems, so it's from Medicare and our compulsory third-party schemes, but not many of our private hospitals provide trauma care in Australia and New Zealand. So if patients can access compulsory third-party schemes, work cover for workplace injury, or other types of private insurances, we can help navigate that for them and optimise those pathways. And of course, providing education to the patient and their family about their injuries and how they can help themselves get better too, and the discharge education. We're involved in a lot of clinical audit and governance with our medical teams, and work really closely with our medical teams within the trauma service and beyond. I mentioned psychosocial impact, and this is really important because quite often the psychological burden of the trauma can be just as difficult for the patient to overcome as the physical injuries. So quite often there's family members that have passed away in the same road traffic crash, or the person who's injured is the income earner for the household, and their young families at home without an ongoing income coming in while they're injured. There could be child abuse or domestic violence, home abuse. I'm not quite sure what the terminology is internationally, but for us, we call it domestic and family violence, child protection, drug and alcohol issues. A lot of major trauma patients are affected by drugs and alcohol, and understanding, how to navigate a lot of these things along the way. Our service, our service is involved in a lot of quality improvement. So it's really important that our trauma nurses are constantly improving their own knowledge and skill set, so that we can then continue to teach that knowledge and skill set to the junior nurses and the developing nurses out on the clinical floor. And so making sure that we can teach things like plaster care, ultrasound guided IV access for when our patients are really complex to put cannulas in down the track, understanding different splinting and processes and orthotics and things like that we can help support from a clinical perspective. It's really important that we're involved in community partnering and consumer and injury prevention. So we do a lot of road safety education in Australia, and also a lot of falls related education, because falls and road trauma are the leading causes of injury and death in Australia and New Zealand. So we partner with non-government organisations as well as our government organisations and do a lot of community messaging. We get our consumers, our patients back to share their stories. And we try and theme our injury prevention campaigns around the different times that we know it's higher risk of injury. We run an injury prevention program. Now, you may have heard of PARTY program. PARTY program stands for Prevent Alcohol and Risk-Related Trauma in Youth. That's what the acronym stands for. This is an international course that came out of Ontario, Canada, close to 40 years ago now. And we've been running it in South Australia for 10 years. And it's a high school injury prevention program. So we go to high schools and educate 15 to 18-year-olds about risk-taking behaviour, making good choices, and avoiding the terrible consequences that we see in our resus rooms every single day. And so this is us celebrating our 10-year anniversary, but we bring high school students into the resus room and show them what we do when they meet some of our trauma patients that have come back to share their story with the students after they've recovered from their injuries. Education is extremely important as part of a trauma nurse role, and we provide what we call Trauma Tuesday education, a little bit of a catchphrase, but every single Tuesday during professional development time we provide education to the emergency department and the ward staff about a topic, and we have a theme of the month, and we run 4 sessions a month. And then on one of those occasions, we share that via Microsoft Teams across the whole state to all the smaller hospitals, so that the smaller hospitals can listen to the education and we can share in that education and learning. We also run a trauma nursing course, both metro and in regional hospitals, and we go out and run simulation and education for nurses across the state. And we run an annual trauma week this is not just a nursing initiative. Dr. Dan Ellis and I work very hard on coordinating this South Australian Annual Trauma Management Week, where we have a series of events and education sessions. Simulation is part of our education. So once a month, we do a multidisciplinary simulation, and we have a theme of the month. And we simulate a mannequin up, or sometimes a staff member. We'll simulate them up, and we will perform a simulation and test our systems and services. And we quite often utilize this for introducing and testing a new process. And we do a lot of debrief after these as well to see how we can learn and develop our systems. Like all services, I'm on my second to last slide now. Like all services, we have some really good key priorities and performance indicators. For a lot of that is around trying to reduce the length of stay in hospital for patients, making sure we're doing their tertiary surveys so they don't have missed or delayed diagnosis injuries. We're trying to prevent hospital-acquired complications, in particular preventing DVT, pressure injuries, hospital-acquired pneumonia. We make sure we optimise the discharge pathways of those patients with the allied health teams to get patients home and sometimes to rehabilitation if they need it. And we want to make sure that we support the patient and their family so they have as positive experience through the journey of a really terrible situation they've been facing. And we also have some key performance indicators on the types of education, research and quality improvement we provide. And ultimately, we do it for this. We do it to put people back together, to get people back to their best self after their injury and make sure that they can be an active participant in their job and their family after their injury. But we also want people to have a great experience. And when you get feedback from patients from the service that your whole trauma system provides, but particularly about the trauma nursing care, about I have gratitude for the extra care and support and being dealt with humanity and professionalism, or that I felt communicated for with really great advocacy, and that it was really amazing that someone kept coming to check in to see how I was going through my journey. It wasn't just about the resus room or the operating theatre. It's about how I was travelling along the way, and just to ensure that they get the best care throughout their journey. And that is it. Thank you very much.
Thank you so much, Nicole. I truly enjoyed that presentation. Thank you so much for sharing your knowledge, the entire program that's been conducted currently over there. For those of you who have worked with a trauma coordinator, trauma nurse, they wear many hats. They do audits, they do research, they're even trauma consultants. So pretty much back in the UK where I was trained, we were very highly dependent on a trauma consultant or rather a trauma nurse as well. So we truly understand the importance of having one in whichever clinical place you practice. So hopefully currently in Malaysia, we don't have one, or rather we don't have a system that trains one, but evidently I think it's very much needed, yeah, as they play, having a trauma nurse or a trauma coordinator, they play multiple roles, and it's a huge responsibility, laid on one person, but I would say that, they do their work perfectly well. So thank you so much, Nicole, for sharing your thoughts.
Very welcome.
Right,
Thank you,
so without further ado, we'll break a little while for the video by the sponsor, which is GE, and subsequently we'll follow on with our third speaker after that. So let's just enjoy the video presentation. Thank you.
Ultrasound is a useful tool to help you in determining the cause of shock, but it can be complicated and take time that is limited. With input from hundreds of ER and critical care physicians, we created Venue, a system that simplifies the complicated steps. Venue's Shock Toolkit is a set of features that focus on some key indicators of patient status: the heart, lungs, and IVC. It assists you in gaining insights needed to help in the determination of the cause of shock.
Hi everyone, welcome back. All right, so I hope you all enjoyed the video by our sponsor GE Electric. Without further ado, let's move on to the third speaker today, which is none other than Dr. Yeoh Chiat. So Dr. Yeoh is currently in the Royal Adelaide Hospital in Australia, completing his fellowship. And Dr. Yeoh will talk on trauma clinical care, sternal fractures, management, and outcomes. So Dr. Yeoh, please enlighten us. Thank you.
Thank you. Yep. Thank you so much, Dr. Tini. Can you hear me from far?
Yep, you're absolutely
Okay.
clear.
Perfect. Thank you so much. Well, the word enlighten may be too heavy. I would say I would like to share the experience with all of you back there in Malaysia. Hello, everyone. My name is Chun. I used to be called Yeoh, Dr. Yeoh back in Malaysia. So yeah, I'm from Sungai Buloh. Thank you for the kind introduction. All right, for the team there, can you post the question that I've already prepared for the audience? We'll try this out. Okay, before I start my lecture for today, just would like to thank you, just want to say thank you to Prof. Dan and also Nicole for being here with us, despite this is the night before a Good Friday and long holidays. Yes, thank you so much for being with us. And I'm also glad that you joined us in this session. And so we would like to also apologize for any technical glitch just now. Can we have the question on board? It's all right. If we can't do it, Theo, can you do it? If not, I just skip that. I go straight to my presentation. There you go. All right. All right. The question, actually, I wanted to ask the audience. You can type in your answer later on. What do you think? How much? Thank you, Nicole. How much energy is needed to break a sternum? All right. So that was the question I wanted to ask. And if you have the answer, you can key in the answer at the Q&A box. Just see what is the response here. Okay. So you have the answer when I proceed with my slides. So, yep, I'm going to talk about sternal fracture today, and these are my content. I have introduction, epidemiology, mechanisms of injury, clinical presentation, management, complications, and pediatric consideration, and my conclusion. I'm going to just plug in the pediatric consideration in all the subtopics that I will make it a small subtopic. Instead, I will put all the pediatric consideration into all the subtopics. Sternal fracture is an indicator of a significant chest trauma. It is usually divided into type A, type B, and type C. So depending on the location, whether it is at the mandibular body, the sternal body, or the sigmoid sternum. So type A is usually associated with simple fracture. Type B will be a little bit comminuted, or maybe a spiral, just a fracture, not that simple, but not that complex. C is complex, where you have very badly comminuted and also displaced sternal fracture. So the spectrum ranges actually from an isolated fracture to a complex injuries with associated injuries like cardiac involvement. The epidemiology worldwide, which I can find from the trauma registry worldwide, is about 3 to 8% in blunt trauma patient. This is done one of the study in Korea and another study in Pennsylvania. And we have also the pediatric incidence of about 1%. The reason being is most likely due to the pediatric, the chest wall is a little bit like, I would say, they are more cartilaginous, so they don't usually break. The sternum bone don't usually break. The force, the impact is usually transmitted and to the chest inner organ without any break in the bone. So they are more compliant. So one of the study, as I mentioned just now, they have a patient. I mean, the population with male being predominant, 57.6%, median age around 60.7. According to the center that I referred to, only 47% was involved in the road traffic accident, because I think that center has more geriatric population. This is in UK, a study of 288 sternal fracture, patient with sternal fracture. The ISS score is around 22.5. Mortality associated with sternal fracture will be around 9%. So, thanks to Dan, we have the experience of analyzing our local data in Australia in isolated fracture in Royal Adelaide Hospital. According to our previous sternal fracture audit, is around 13%. Well, the mechanism is divided into two: the direct or indirect. The question I asked just now, how much energy is needed to break a sternum, is around 4,000 Newton. So if you are doing CPR chest compression, that will generate around 300 to 500 Newton. 4,000 is like at least a Mike Tyson punch. Yep, 4,000. A normal heavyweight punch will give you around 2,000 Newton. So 4,000 is quite high. Or a car traveling at 30 kilometer per hour, that will generate enough energy to break the sternum bone. Okay, it is also associated with blunt chest trauma and also sudden deceleration force, like maybe a seat belt or maybe something heavy fall onto the sternum bone itself. The indirect one will be usually due to the hyperflexion injury, where you hyperflex your chest wall and your spine, resulting the sternal fracture, indirect fracture, and also the vertebral body fracture. So this is indirect. The sternal fracture associated with seatbelt is a hot topic for those car manufacturers. They usually try to correlate or try to find out what is the cause of sternal fracture associated with the seatbelt, and they try. I mean, the manufacturer is very heavily spending a lot of research on this, and one of the study from Canada, if I'm not mistaken, has stated that yes, it is associated with a sternal fracture. Depends on how you put on your seatbelt. This is the standard 3-point harness seatbelt. In Australia, all the kids, they will have the booster seat, right? So you have 3-point, and then this when you have a sudden stop and the force generated to the sternum is quite high. Some of the kids, we see more in Malaysia, right? Some of the kids, they won't be compliant to the seatbelt properly, so they'll put under armpit, or maybe they put improperly. This is more associated with other intra-abdominal injury. The photos are taken with the parental consent. Okay, then sternal fracture in unrestrained unrestrained drivers. One of the Turkey studies showed that without a seatbelt, a patient driver without a seatbelt, sternal fracture can be caused by the airbag which is deployed, or the chest can just literally hit the dashboard or the steering wheel. That will cause the force is enough to break the sternum bone. Usually, they will present with chest pain, tenderness over the anterior chest, and difficulty in breathing. Signs will be localized swelling, bruise, seatbelt mark, or deformity. However, if a patient with a sternal fracture, you should also look for other associated injuries, like lung, pulmonary contusion, rib fracture, pneumothorax, or cardiovascular injury, cardiac contusion, myocardial injury, thoracic injury, and other musculoskeletal injury. As I mentioned, if it is due to a fall with the indirect force to the sternum, it will cause some vertebral injury or retrosternal hematoma. Look for it. And other systems like intra-abdominal injury, long bone injury, traumatic brain injury, And one of the studies say if the patient treated with sternal fracture, especially in population, you should think of non-accidental injury as well. The pictures are taken from Trauma Life Support Manual. Yep, you can do further reading on that. The imaging modalities, standard practice in Malaysia, most of the hospital, we will do a first chest X-ray. If the patient is able to sit up, then you can do a lateral chest X-ray. Lateral chest X-ray can pick up 60 to 67% of, that means sensitivity of 60 to 67%, according to the paper that I have read. Well, the gold standard is still a CT scan, which can pick up to 95% of the sternal fracture. In pediatric population, you might, if you want to apply the concept of ALARA, that means you want to reduce the radiation to the population, you can consider an ultrasound. I think ultrasound method is quite common in Malaysia, where we can use the ultrasound, either a transverse or vertical view, to look for the break in the cortex of the bone. As one of the study has mentioned, ultrasound application in diagnosing a sternal fracture in pediatric population. In PITS as well, if you do a lateral X-ray of the chest bone, of the sternal bone, there's some caveat because of the ossification center. In PITS up to maybe 14 years old, the ossification center tend to fuse in the late puberty. So the ossification might look like a fracture sometimes. So like the usual saying, I need correlate clinically. Is there any role of ECG and echo in a patient with sternal fracture? The answer is yes. You need to do some screening tests for other associated injuries. Screening tests like, ECG that shows sinus tachycardia, ST segment changes, or conductive disturbances. According to our experience, the bundle branch block or the AV block will be highly associated with myocardial injury in the patient with sternal fracture. Echo, if you want to diagnose or you want to see the cardiac function, echo during trauma resuscitation is quite important. Not just seeing the myocardial injury, we also want to see whether there is any need of inotropes or volume resuscitation in trauma patient. Pericardial effusion, we can see it especially during our fast scan to look for thrombus and valvular rupture. According to AAST guideline, AAST injury scale for cardiac injury, they involve the ECG finding as without any cardiac injury as their first grade of, grade 1 of cardiac injury. And ECG is quite important in diagnosis, in a myocardial injury diagnosis in this patient. Can read on later. Cardiac biomarkers. We need to do troponin T for every single patient that comes with sternal fracture. Well, according to Trauma Life Support Manual, we advocate for a patient with a severe trauma for trauma panels. In the trauma panel, that we have already included the TROP-T or TROP-I according to the center, the high sensitivity troponin T or troponin I according to center as a baseline trauma panel blood investigation. However, according to the literature, negative troponin has low initial blunt cardiac injury sensitivity, and it is not specific in asymptomatic chest trauma with normal ECG. What does it mean? So that means if the patient comes with sternal fracture with a low troponin T, troponin level, it doesn't mean that the patient does not have blunt cardiac injury. Okay, when it is getting higher, when you have significant chest trauma, yes, it is associated with higher degree of myocardial injury. However, if the patient has no chest, asymptomatic chest trauma, not really painful, you see the ECG, is normal ECG, normal, no pneumothorax, no refraction, nothing else, it's not that specific. Even though if you find the troponin T high in this kind of patient, it is not specific for myocardial injury. All right. So this is the evidence so far. So when it is recommended, so when you have an ECG abnormalities, the patient has a new onset of, let's say, ST depression, or maybe you have a patient with ECG of AV blocking. If the patient is symptomatic, just like acute coronary symptoms, chest pain, sweatiness, all this chest, myocardial injury or ischemia related injury symptoms, you should consider cardiac biomarker. If those patient has unexplained hemodynamic instability or any heart failure, you should also consider CHOP-T. Or any if it is due to if it is a sternal fracture in children, you should also consider doing the cardiac biomarker to screen for any myocardial injury. Red flags for a sternal fracture: if you have a high cardiac biomarker, as I mentioned just now, respiratory distress, because we have to back in our mind, we have to rule out any other associated injuries. Those patients with dysarrhythmia, those patients with abnormal echocardiogram, or hemodynamic instability, those will be the red flags for patient with sternal fracture. Management-wise, what do you want to do with a patient with sternal fracture? Isolated sternal fracture, like if you have a normal ECG, chest imaging without any clinical red flags, you can actually manage the patient as outpatient. This is from the up-to-date guideline, guideline from up-to-date, and also one of the center from K. And pain management, of course, and rehab. So usually in Malaysia, we will try to admit the patient with sternal fracture as much as we can. However, according to worldwide recommendation, you can actually treat it. If it is isolated fracture, you can treat it at home. Depending on your center resource and the follow-up availability. Consider admission if those patients that need continuous cardiac monitoring. As I mentioned, if you have sometimes it is associated with a myocardial injury, so you would like to have a continuous cardiac monitoring, so you consider admission. Or aggressive pain control. It is so much of displacement, the degree of displacement is so high, the patient is so painful, then you consider regional anesthesia, systemic anesthesia, or a treatment of any other associated injuries. I remember a few years ago, we performed a parasternal block for a sternal fracture. So that will be a choice rather than serratus anterior or ESP, is quite patchy. So you will consider parasternal block for a sternal fracture. Operation for sternal fracture. Well, not much of literature supporting that. A few case report saying that, you can consider wiring, you can consider also plate and screws. Well, logically, plate and screw will hold the fracture fragment better. So people will, if cardiothoracic surgeons, sometimes they prefer the screw and plate rather than the circlage wire. This is according to what I have studied so far. Short-term complication. Chest pain, of course, when you have chest pain, then you impair the ventilation. As we know, sternum is involved in the respiratory process. During inhalation, the sternum will actually move upward and superior and anteriorly. It's a pump handle action. So any movement will cause pain. So you have to give the patient adequate analgesia for that. Surgery related, like intraoperative memory artery, because it is situating quite close to the sternum. Wound seroma or loosening of the fixation material also reported. The long-term complication like non-union, chronic pain, pseudoarthrosis, which cause much of cosmetic effect, and osteomyelitis is reported in one of the African study of a patient with sternal fracture. What do you do after that? If you have the ability to follow up the patient as for your trauma service in the future, So you would consider a clinical reassessment in 4 weeks time. Consider repeat imaging like X-ray, lateral X-ray for the displaced fracture. And also we will expect full recovery in one of the study mentioned for isolated injury to 8 to 10 weeks time. Okay, so with that, actually, that will be my last slide, but I would like to share with you the guideline that we have for a suspected blunt cardiac injury pathway that we developed in Royal Adelaide Hospital in South Australia. So if you have a patient with a significant anterior chest trauma or any blunt aortic injury, well, the usual trauma resection, resuscitation and investigation, and don't forget the ECG. If you see the ECG has got any STEMI, you can actually alert your cardiology team as soon as you can. Consider post-STEMI, that means consider the STEMI pathway in Malaysia. All right, and new onset of ECG abnormality, you would consider close cardiac monitoring, do some repeated high sensitivity troponin and cardiology consultation. Unexplained tachycardia or bradycardia, obtain the high sensitivity troponin, and according to the result, you do your disposition plan accordingly. If those patients who has chest trauma but with a normal sinus freedom, or maybe patient has pre-existing atrial fibrillation, let's say, or pre-existing AV block. If the patient is hemodynamic stable, well, PCI is unlikely. Okay, if those with hemodynamic instability, you will consider a TROP and go on with the algorithm. Okay, conclusion. Early recognition and intervention improves the outcome of sternal fracture by using the imaging, biomarkers, and clinical judgment and appropriate risk stratification. Management varies. If those patients with isolated fracture need conservative care, those severe cases will need resuscitation and hospital admission. Rehab and reassessment help in prevent the complication and enhance recovery during the process of recovery. And pediatric sternal fracture require careful assessment because of the flexibility, which I mentioned just now, and the risk of other serious thoracic injury. Okay, after this slide question, you can key in your question at the Q&A box, or later on during a Q&A session, you can ask. That will be my references. Thank you. Ratini, back to you.
Thank you so much, Dr. Yeoh. Wow, that was really lovely. I think Dr. Yeoh did a fabulous job on giving us insights on sternal fractures, the latest evidence-based guidelines, as well as complications, outcomes. It was absolutely fantastic, Dr. Yeoh. Thank you very much.
Thank you.
And
Thank
we
you,
look
Dr.
forward to having you back soon too. All right.
Yep,
So
it'll be in
thank you,
July.
Dr. Yeoh.
Yes.
So without further ado, we are moving on to our last speaker and final speaker. Allow me to just give a brief introduction once again. Our final speaker is Associate Professor Daniel Ellis. He is the Director of Trauma at the Royal Adelaide Hospital in Australia. He co-chairs the statewide South Australian Trauma Service, or rather known as SATS, Trauma South Australia. He is a consultant in emergency medicine at the Royal Adelaide Hospital. He is also the pre-hospital and retrieval physician, SAAS, MedStar, Emergency Medical Retrieval Service. Prof. Dan is also the Clinical Associate Professor, Faculty of Health and Medical Sciences, University of Adelaide. And he is also the Associate Professor in the School of Public Health and Tropical Medicine, James Cook University. So Prof. Dan will guide us in his topic called Resuscitating the Critically Ill Patient, What Really Matters. So I really can't wait. I hope all of you all out there are excited as well. Hi, Prof. Dan. Welcome on board. It's a pleasure to have you with us. Thank you for joining us.
Hello, can you hear me first of all? Just double check.
So, Prof, then if you're ready, the floor is all yours.
Can I just confirm you can hear me?
Dan, we can hear you, but it's a little bit low. I think you need to up your speaker or something.
Okay, well, I'll try and speak loudly. I've never been accused of speaking quietly. So, will that be okay, Nicole? Or
That's better when you're closer, yeah, but still a little bit low. That's all.
okay. Well, let's see if we can. Hopefully, you'll be able to see my slides as well.
Yes, we can see your slide then.
Excellent. Okay, so many thanks. It's a great pleasure to be here and a great honour. Get a bit more light. It's a great pleasure and honour to be here speaking to everybody today. So thank you for hosting, for asking me to speak at your meeting. And thank you to Chun for organising all of this. It's been a great help having Chun at our organisation. And we'll be sad, as much as happy as you are to have him back, we'll be very sad to see him go. So what I really wanted to talk about briefly was the resuscitation in critical illness, and perhaps in a slightly different thread to what you might think. This talk was originally given in a slightly different format at the London Trauma Conference last year in London, which was in fact the Peter Basket lecture, which I gave. This talk actually was the genesis of many months, if not years, of thinking about what it is that we do in critical care medicine, in particular in trauma, and what it is that we should be doing and what it is we should be focusing on. So I'm here, I live here in Adelaide, and so does Chun at the moment. And the little yellow circle over there is the Royal Adelaide Hospital. This is where we work. Obviously it's a very nice place to live in what is actually a very big country. And I've just put a little box there of the size of Malaysia in comparison to the size of Australia. And you can see that we obviously have a great deal of differences in our geography and therefore in our demographics of our patient group. So not everything that we do and say, or what I say here in particular in pre-hospital medicine, will necessarily apply verbatim, but there's a lot of principles that I want to share with you. So on to what we're talking about really. What actually really matters is the key, and how do we go about discussing that concept? Problem really is with critical care is that we have a problem in its own right, and that is that emergency and trauma and critical care are very high octane and exciting. And actually, what I want you to understand is what really is most important isn't very exciting at all, and it's actually quite boring. And I'll just give you as an example a trauma resuscitation that we had a few years ago with a very learned and wise colleague of mine, an excellent resuscitation for a very seriously injured patient who was bleeding to death, in fact, and was treated very well. But when we audited the process the following week, when the blood gas came up and the ionized calcium was flagged, the ionized calcium was down at 0.7, which, as you'll know, is very low. So when we asked the team leader what he'd done about that, he looked very crestfallen and said he didn't even notice it. It wasn't even brought to his attention, although it was his responsibility to know. He didn't even recognize that. And obviously that had a meaningful impact on the patient's coagulation, even though the patient did well. It was why he came to me afterwards and said, why did I miss that? What am I doing wrong? Why something as obvious as that? And that's really, when we come to the nitty-gritty, that we have to be manifestly interested in all of the details, not just the exciting details. So let's take a step back and examine, like this bird that's made up of hundreds of drones, we have to choreograph resuscitation, and we need to get the elements of resuscitation accurately choreographed if we want to be successful. And if we look at three particular elements, we'll look at environment, we'll look at humans, both workers and patients, and we'll look at medical education. So let's look at the environment first. I think we can agree. I don't know about your emergency departments in Malaysia, but certainly emergency departments in this country are a mess. Our modern trauma rooms and emergency departments are overcrowded. We have sick patients mixed with well patients. We have big traumas. We have big medical cases. We have everything coming in the door at the same time. And we need to pick out what is bad and what isn't, and we need to do it quickly. So it's fair to say that most emergency departments around the world can be likened to a dumpster fire for the American vernacular. Also brings us to the question of, must we accept this mediocrity? And unfortunately, we're often in a position where the answer to that question is only if we can achieve it. So the workers, how about the workers? And that's the doctors. That's and I'm going to focus on doctors as a doctor myself, but I appreciate that the healthcare team is vast and has many facets. But doctors are trained in an old-fashioned way. So they're trained to take a history and examination, special investigations, pondering and thinking. That's still relevant for a lot of medicine. But what about us in emergency and critical care and trauma? How long do we actually get to clerk in a patient? How long have you got in your workplace if you think about your critically ill patients? And the reality is you've got hardly any time at all. In emergency medicine and trauma, you make a split-second decision. You pull back a curtain in a cubicle, you look at a patient for 5 or 10 seconds, you look at the monitor, and then you make a decision about whether or not you need to stay and do something, or whether or not your patient is stable enough to wait 5, 10, 15, an hour. That decision is split second. And what we actually need, instead of long history examination investigations like a lot of other medicine, we need to be dynamic and fast thinking. We need rapid decisions that we need to be able to make without all the information. Most importantly, we need attention to detail. We need to get the little things right all the time. We really need to sweat the small stuff. And we need to become obsessive checkers. In fact, what we need to be is a little bit OCD. So can we actually build better emergency critical care and trauma doctors? And how will this impact the teams in which we work? And will it actually benefit patient care? And Dr. Frankenstein, we know, tried to build his own perfect human, and perhaps we need to try and build our perfect doctor. So if we're going to adopt that philosophy, let's look at some zones of interest. And I want to focus on 3 particular areas: leaders and teams and performance. I want to look at the medicine itself, and then I want to look at us, the people. So leadership. I put on Oppenheimer, because I think Oppenheimer is a really good example of somebody who had to lead a flash team, and we'll come on to that shortly. But what was his task? What was he given? He was told he had to build the bomb really quickly. He was told that if he didn't build it quickly, that the Germans would build a bomb quicker, and then the war would be over and the Allies would lose. He was given a list of all the geniuses that he had to work with. And these people were bona fide geniuses. And I'm not using that term lightly. We're talking about physicists whose names are legends in the books that we've all studied, like Niels Bohr and Leo Szilard. All of these folk were supposed to work with Oppenheimer as part of his team. To say they were genius is almost an understatement, especially in the art of theoretical physics. He was also part of a bigger team. So he was part of the army. The army was overall in charge. So we actually had a non-scientist manager in the form of an army general. And also he had, of course, one of the greatest legends of all time from the science world, although not directly in the Oppenheimer team, was also involved, and of course relationships with Einstein had to be preserved at all times. Why does that liken us to trauma? Why do I compare that to trauma? Well, you think about your average trauma case that comes through the door. You also get a job that you have to do really quickly. You've got no time. It's not something you can stop and think about. You also get a list of geniuses that you have to work with. Your trauma team is full of geniuses. All the doctors, the nurses, the allied health, the radiographers, and in particular surgeons and whatnot. These are all very clever people that all rightly think they're awesome, and most of them are awesome, but you have to tap that genius. You've also often got a non-medical manager in charge, which means you work for a health service which has different priorities to you. As opposed to Oppenheimer only had to not upset Einstein, We're not allowed to upset anyone because most surgeons already think they're up there with the gods. So you've got a real job on your hands to keep this team on track. So how do we do it? What do we do? Well, most people seem to think that leadership is something that you can easily teach, something that you can go to a course, maybe a 2-day course, have a nice lunch, and you'll come out at the end of that course as a leader. Well, I don't think that's the case personally, and I've been to several leadership courses, often with the same people over the course of my time in Australia, and most of them go in as pretty ordinary leaders, and they come out as pretty ordinary leaders. They don't really get the skills that they need from these courses. So what we have to ask is, are we batting up the wrong tree here? Can you actually turn an average leader into a good leader? But can you even turn a poor leader into a passable leader? Because this is really important for our critical care management. I want to give you another historical example here, because this is also very pertinent. You might not know this chap. This was Ulysses S. Grant. And he basically started in the US military as you can see, in 1839. He worked hard in the military for 15 years, made it up to the rank of captain, and was then told he had no future, wasn't going to get anywhere in the army, and he left, and he went and ran his own farm. What happened? As you all know, in 1861, the American Civil War started, and Ulysses S. Grant went back to the army, where all of a sudden it was noticed that it was a different ball game. Within 5 years of rejoining the army, he went from his original rank of captain to the head of the entire American army. 2 years later, he was the president, and he was president for 2 terms, 2 consecutive terms, and arguably one of their finest presidents. So what happened to Ulysses S. Grant when he left the army? Did he do a course? What turned him from an ordinary leader with no prospects into a fantastic leader? And I would argue that it was always there, it was just never tapped into. You can apply the same rules to something more simple and straightforward, like football. How difficult can it be to get a team of incredibly talented footballers to kick a ball around, put them all together, get the best ones in the world and say you win? Well, we know that actually most of the managers who have these legendary teams still don't win all the time. Oftentimes they don't win at all. If we try to look at how many legendary football managers there'd be in the last 50 years, we'd have a very small number compared to how many have actually tried. Do they do courses on manage? How do the good ones be good? And also, what's really important from our perspective is how many legendary managers were also legendary players, which, if you think about it in medicine, is really important to us. If we're going to trauma team lead, we want to be able to walk the walk. And there's a big impression that if you can't walk the walk, then you shouldn't necessarily be talking the talk. And that, I think, is quite a pertinent example of what of leadership. So what does Hollywood say? Because in reality, we have a bunch of medical specialists, a bunch of individuals forced together in a high-stakes situation. So you might be what we call a flash team. So everybody works together in the same hospital, but they don't actually form the same team time and time again. They're just thrown together for this critically ill patient. It's genuinely what we call a flash team, a team that has just been thrown together to work. It's a team of geniuses, but they need to be led, and the genuine hands-off leadership is often done poorly. So do we have a solution to this? And as I said, well, we have to look to Hollywood sometimes for our solutions. And when we look at Hollywood dream teams, and these are 2 examples of Hollywood dream teams, we find that what's very interesting in the Hollywood dream team is not that the team. So both of these, Ocean's 11 and Money Heist, are 2 examples of a flash team. So it's a team of amazing experts that are put together to do a bank robbery, both of these instances, to do some criminal venture. So basically this team of criminals is one of maybe a safe cracker or a sniper or a kung fu expert, individual geniuses all put together to deliver a result. That's all very realistic, to be brutally honest. You can get the expert sniper, you can get the kung fu man. What is the role in these Hollywood movies that's actually unbelievable? Well, it's the leader. It's actually the leader, the guy with the beard in Money Heist or George Clooney in Ocean's 11. These are the people that don't really exist because they are able to gel this Flash team together in perfect fashion. So no faults happen, no arguments, nobody fights with each other, even though they're all a bunch of criminals. They all get on fantastically well. And that's the fantasy, is that the leader is the fantasy. So let's quickly look at a couple of leadership aspects. I just want to focus on these for a sec. And a couple of these are really important points. I think a really good leader should be able to extract the brilliance of those around them, first of all. He needs to accept that sometimes being in charge means pissing people off, although it doesn't mean pissing people off all the time. That's the opposite. Attention to detail we've talked about. The leader has to be the backstop for this. That's on you. And great leaders are great simplifiers. So they need to be able to cut through argument and debate, and they need to be able to present their team with a very straightforward solution. If you overcomplicate, it's a disaster. A few more, some of these are attributable to Colin Powell, so I've put him up there. Perpetual optimism as a force multiplier. So you need to be optimistic. Procrastination, this is really important for us in medicine. We never really have 100% certainty with what we do. And actually, if you're waiting to get to 100% certainty, then you're procrastinating. You're not delivering the care you need because you're waiting for there to be zero risk. That will never happen in our line of work. So the best advice here is when your gut is in the 40 to 70 range, when you think it's between 40 to 70% likely that you're right, then you got to go with it. Because if you wait any more, you'll be delaying and waiting and delaying and waiting, and that's going to do your patients no favors. The final point about great leaders is this concept of if it ain't broke, don't fix it, which is really a very lazy statement. Doesn't really it encourages a very negative approach. People think, oh, it's fine. You'll never improve. You'll never get better. You'll never strive to be the best if you're constantly thinking, well, I'm not going to move forward because it doesn't look broke to me. So what is our solution to leadership? Well, perhaps we need to stop trying to make everyone a great leader and perhaps focus on Flash team dynamics and the individuals. The ants and the bees, they do it really well. The ants and the bees, they go out every day, they do their job. Nobody wants to be the queen. Everybody's happy doing their job. Why can't we do that as humans? Well, the reality is humans don't really want to be. Everybody wants to be in charge. Everybody wants to be the queen. And as a group, we can't collectively get over ourselves. We want to be in charge and we want to be the boss. So that's important because we also need to remember if the concept of the kingmaker versus the king. So you might be the boss, but oftentimes it's the person that elects the boss or advises the boss that's the key. And if you are prepared to go without the ego and the media, then actually you can have much more influence as the kingmaker rather than the king. And of course, succession planning is also highly relevant. We do that really badly in medicine. We do our job and we say we're great, but we're not really fostering the next generation. And what we need to look for is not somebody who we can turn into a leader, but perhaps we need to start looking for natural born leaders within our group, whoever they may be and whatever age they might be. So on to the medicine briefly. I just want to flash through a couple of these bits. This chap, Paul Ehrlich, designed the concept of the magic bullet. He felt that there was something in medicine that you could give every patient and it would make them better. A magic bullet, if you like, for all cures. So what do we think about that? Well, again, if we look at Hollywood defines how we act as critical care clinicians via the TV and via the movies. We're supposed to run to emergencies. We're supposed to arrive looking cool and unflustered. We're supposed to give 50 cc's of something. It doesn't really matter what it is. We just give 50 cc's. Has to be stat. Then we wait for a few seconds. Then whatever the patient had, it goes away. They wake up. They hug their relative. Everybody's in tears. Everybody claps. And the doctor wanders off with the insanely attractive nurse and everybody's happy. This is what Hollywood thinks medicine is. We know that the reality is a whole stack different. It's much more boring. We have to pay attention to what we do. We have to aggregate our marginal gains. This is a really important concept. If everyone in our team behaves 1% better than they were, then you have if you have a team of 20, you have a 20% improvement in your team. Do you think about that? What else will give you a 20% improvement in your team function? Nothing. But everybody just doing 1%, that's easy. And all 20 of them will give you a 20% improvement in team dynamics. We also need to recognize that time is the most important single parameter. And whatever happens, if you identify and stop and treat it earlier, it's going to be a better outcome. Which brings us a little bit to the location. I'm not going to spend a lot of time on this, but there is a growing school of thought that waiting for people to get to hospital before we initiate critical care treatment is perhaps a mistake. And the people that are going to die will already be dead by the time they get to hospital, or so physiologically damaged that you can't recover them. Perhaps we should be taking the hospital to the roadside and starting critical care treatments earlier. And if you're interested in that area of pre-hospital retrieval medicine, I encourage you to have a look at this book. Obviously, I have a vested interest in it, but this is about pre-hospital and retrieval medicine and what we do in that arena. One comment on luck, because everybody says it's lucky, but what you have to remember is that luck is really a factor of the work that you've done, the preparation you've done, the courses and the exams you've done, and the knowledge and experience you've gained, plus the insight to apply it. And as the famous Chinese proverb goes, luck is actually what happens when preparation meets opportunity. So it's not all down to good luck. And we need to make sure that we allow time within our medicine to do audit and governance, which is where we look at what we've done and make sure we've got nothing to learn from or nothing to improve from that we can change. Because, of course, we always will. When you do audit and governance, you will find things that you can do better. You can always do better. And that's not very popular within health economics, because nobody likes to pay doctors and nurses and clinicians to sit around and discuss what they did, even though it's of critical importance. So I'm going to close up a little bit with a bit about ourselves, because I think it's really important in the high-powered jobs that we do in critical care that we look after ourselves and pay attention to ourselves, and also deal with some of the concepts of arrogance and ignorance, as well as the universally important insight. And this Peak Performance book by Stevie Hearns is an excellent book. It's not about pre-hospital, it's about your performance, which is really important. There's no shame in having self-doubt. And you need to be aware, and I'd urge you to look at Steve Peters' book, The Chimp Paradox, which talks to us about how we can regress under pressure to respond very poorly to pressure. So if we're put under terrible pressure, we often let our innate inner chimp, if you like, escape and go crazy. And that means that we lose control of the situation and things get out of control very quickly. So you need to understand your own psychology and how you perform under pressure in order to address that. And you're hopefully all familiar with the Yerkes-Dodson curve. This curve basically shows how when you're not very interested, you're actually performing pretty poorly because you're bored and it's not stimulating. As things get more and more exciting, you perform better and better. So the peak of this curve here in the middle, where it says arousal, means where you are the most aroused and stimulated is where you're going to perform the best. But if you carry on going down the arousal side, you become less and less efficient. So there's a curve, and you can drop off the end of that curve, and the more stressed you get, the worse your performance gets. So you need to put your critical care performance in medicine into a position where you're in the optimum part of the curve. And we all know, if you look at emergency physicians and trauma specialists, we're all very, very disinterested until it's very exciting. But the drop-off is still the same. Despite the early bit being different, your drop-off is still the same. And that's because humans are more important than hardware. And humans have varying needs, which are between physical, cognitive, social, and spiritual. And we need to cater for all of them if you want to get the best performance. Don't forget also the power of negative thinking. This is about making plans if things go wrong. You need a plan when your plan A goes wrong. And if you think your plan A is not going to go wrong because you're so good, then think again, because that's exactly what you need. That's why we make difficult airway plans. That's why we say, what are we going to do if we can't get in? A plan A, a plan B, a plan C. And it's not a sign of failure. It's not a sign of being weak to make a failed airway plan. It's a sign of great practice and you must use that negative thinking to your advantage. And it's not only a medicine thing, you can do that in your day-to-day living. You should be well aware of that. As Mike Tyson famously said, everyone's got a plan until I punch them in the face. And you've got to have a plan ready for when it all goes wrong. And that applies to all your walks of life. Finally, really, is insight. Insight is another great gift that we can't really control, that you've either got or you haven't. You either know that you're the emperor with no clothes or you don't. And of course, in the end, you've got to apply that to a world where nothing really matters very much and few things matter at all, which is, again, a difficult balance in the critical care space. We all know medicine is a humbling vocation. And if you haven't been humbled, then again, you've probably got an insight issue. So we've looked at the zones of interest. They've all got relevance to what we do. So how's our emergency clinician looking that we were building? Well, look, ideally, this emergency clinician might have all of these skills. You might want that. But the reality is, if you look at the skills above the line, I would argue that these can't be taught. It's very hard to teach any of those four: humility, vocation, insight, and leadership, which means we need to focus on below the line. We can improve our knowledge, we can pay attention to detail, and we can aggregate our marginal gains. And we can work hard to be a player in a high-performance team without having to be obsessed with being the leader of that team. So really, what does really matter? Well, the argument here really, I would say, attention to detail is what is key, and actually learning how to be part of a dynamic high-performance team. Thank you very much. That was my last slide. This is just to remind you there is a conference in Adelaide, just a short hop of 10 hours from you, and you're very welcome to join us if you have the time. Thank you very much.
Thank you so much, Prof. Dan. Wow, what a really inspiring presentation. I am truly inspired, and I'm sure the audience must be inspired as well. I think Prof. Dan has basically addressed lots of misconceptions, basically giving us a lot of inspiration and making things that actually sound impossible to being possible at the end of the day. Thank you so much, Prof. Dan. So to the audience, if you have any questions, you can put it up at the Q&A box, and we will be answering them in a bit. We will now take a very short break for a video presentation by DGE, which is our sponsor, and after which we will follow through with the Q&A session with all our 4 distinguished speakers. So without further ado, we're going to break a little while for the video presentation. Stay tuned.
Ultrasound is a useful tool to help you in determining the cause of shock, but it can be complicated and take time that is limited. With input from hundreds of ER and critical care physicians, we created Venue, a system that simplifies the complicated steps. Venue's Shock Toolkit is a set of features that focus on some key indicators of patient status: the heart, lungs, and IVC. It assists you in gaining insights needed to help in the determination of the cause of shock.
Hi everyone, welcome back. Right now we've come to the end of our session, the Q&A session. So if it's all right, we would like to welcome all 4 of our distinguished speakers on board. Yeah, fantastic. All right, I've got a question for Miss Nicole. A very I think the question is probably going to be based on your experience. So the question goes, how do trauma nurses balance rapid clinical care and patient advocacy? Could you enlighten us on that? Thank you, Nicole.
Sure. And I think that differs depending on the stage of care. Of course, in the high-performing team dynamic environment of the resuscitation room, the focus needs to be on getting the clinical care done at the right time. But I do believe that obviously in a conscious patient, we should always ensure that we're communicating with them and keeping them informed about what the next steps are, so that, you know, we have to remind ourselves and put ourselves in the place of the patient lying on a barouche in a scary resus room around lots of people. But of course, that differs for the critically unwell intubated trauma patient that is rushing to theatre. You know, at that point, the advocacy then turns to supporting the family during the family conversation when we're updating them and supporting them. Then during the patient journey, the advocacy is always around that communication and making them feel informed. And we always find that patients that are informed about their care plan and given some real great tools to use and some information to inform them so they can become actively involved in their recovery, find patients become more engaged and more interested in that as well. And then making sure that their family unit is involved in that so they can support them and understand what the next steps are through the hospital. So it can be a tricky balance, of course, but a lot of it all comes down to communication.
Thank you so much. I would like to also congratulate you, Nicole, for the excellent work that you've been doing abroad. Well done. My next question goes to Prof. Dan. If you could guide us with the next question. So the question goes, how do we avoid the pitfall of resuscitating too long before definitive care has been established? Of that?
Would that be referring to the pre-hospital resuscitations, as in staying too long on scene before going to the hospital, or is that referring to it when you're already in the resuscitation room, staying downstairs too long? I just need to qualify the question.
It's basically when you mentioned that you prefer a no ego zone. So how do we say that we've done enough for this patient at this point of time, and this patient needs to go to OR, for example, instead of staying, playing the resuscitating game, down there in the ER, when we all know what the patient actually needs.
Yes. Okay. So no, that's absolutely fine. That does apply actually to pre-hospital as well as in hospital. And the reality is you do what needs to be done. So it's really important to get a grasp on the interventions that really count versus those that you really fancy doing. So sometimes somebody might say, oh, I want to, the orthopedic surgeon's a good example. Our orthopedic colleagues often will say, oh, well, I need to do something with this wrist, but the patient is bleeding in his belly. So this is where the team leader, the amazing beast that I've been talking about to try and get this fantasy person, this is where the team leader has to be able to explain, no, we're not going to do the wrist and we're not going to do this. We're actually going to go to theatre now. We're going to stop doing stuff in the resus room. We're going to go upstairs. We're going to, if you can explain and simplify what you're trying to deliver. So somebody wants to stay longer in the resuscitation room in the emergency department and give more blood, for instance, then it's up to the team leader to say, well, remember, the blood that we're giving is just pouring into the belly. So until we stop the blood in the belly, there's no point us rushing to give more blood, even if the blood pressure is very low. We need to get upstairs, tie off the bleeding, and then we can give more blood. And so That's that fine balance of saying I'm going to give a couple of units and then I'm off. So really, it's about doing what you have to do. If a patient has an obstructed airway in your emergency department, then taking him upstairs and taking 5 minutes to get him to the OR with an obstructed airway is not going to do him any favors. He's likely to have hypoxic brain injury or other problems. So you have to manage the airway and then you go upstairs. That doesn't mean you spend an hour downstairs. You do a quick high performance intubation and then you go upstairs. So you've got the airway is secure and now you're up and now you can leave. So you do what you have to do. You don't stay and do things that are unnecessary. That's really the key to pre-hospital and to running a good trauma, for example.
Thank you so much for that, Prof. Dan, and thank you so much, Miss Nicole, for the excellent answers. I would like to call on board or rather introduce our panel, an extra panel today, which is none other than Dr. Shah Jahan, which is currently the president of the Malaysian Society for the Care of Trauma, the MASCOT Society, and he currently is the head of the department for the emergency department of Hospital Sungai Buloh to say a few words. Dr. Shah, if you may. I think we need some help with the audio.
Can we hear? Right? Okay. So I think first and foremost, on behalf of the Malaysian Trauma Society and MASCOT, we definitely love this opportunity and like to thank Dan and Nicole for two things. One, for really taking care of Yeoh, and he's been having a great time learning lots there. And secondly, for definitely being first time, I guess, we are two organizations here being introduced through this amazing webinar opportunity. And having you here, both of you, it's a grace to the academic scene, especially when we are touching on very delicate topics coming across the lines of clinical as well, administrative, or even team dynamic leadership, and not to mention how communication goes through across cultures, egos, professions, and how do we see across all this into making everyone focus on the main interest of the whole team, which is the patient's life. And I think that conversation has been ongoing for many and many occasions and platforms. And it's just so great to hear perspectives of various centers, various experts imparting this wisdom onto us. And I think onto the crowd, which is been subscribing to most of the MASCOT trauma series, this is definitely a beneficial opportunity for us. I've also been made to understand, Dan, that your presentation that you just gave about was a recipient of quite an honorary award some time back, and I think rightfully so. Nicole, great job. Definitely our nurses hearing and how you have been providing great leadership in trauma nursing it's inspiring, and it's something that we definitely look forward for, not just in Malaysia, but also to our regional listeners around this region. Again, Azlean, amazing presentation, and Ratini, always being the perfect chairperson for these events. Yeoh, we're definitely looking forward to have you back too. Dan, loan time is over, taking him back. And really, thank you very much for having have him there. And we definitely look forward to send more candidates to you, of course, if you're willing. And we look forward for this collaboration on the long term. Definitely. Again, from the Malaysian Trauma Series CNE team and MASCOT, thank you very much, guys. And definitely look forward to having seen you perhaps in Malaysia in physical presence one of these days. Thank you very much.
Thank you very much for your kind
Everyone,
words.
thank you so much.
Thank you so
So I
much.
guess that's a wrap. Once again, thank you so much, Nicole. And then you guys are truly inspirational. Thanks a lot, Yeoh and Azlean as well. It was very insightful. We look forward for future collaborations soon, I hope. Take care and enjoy yourselves. Goodbye, everyone.
Thank you. Bye.